Of our webinar series related to epilepsy surgery techniques. Today we have a terrific session. We have two outstanding speakers. We are going to start our session with Dr. Arthur Cuquier. He's professor of neurosurgery and director of the São Paulo Epilepsy Clinic. And he will speak about deep brain stimulation in the hippocampus for medically intractable epilepsy. Following his talk, Dr. Jason Chirag, he's a professor of neurosurgery and director of functional neurosurgery at Yale University, and he will speak about responsive neurostimulation. So after the two talks, we will open the session for questions, and hopefully we'll have a very good discussion about those two exciting topics. So with that said, please go ahead, Dr. Cuquier.
Good morning, everyone. Jorge, thanks you for the kind introduction. I will start by sharing the screen. Can you see the screen?
Yes.
Looks good, Arthur.
Perfect.
Okay, perfect. So I would like today to discuss some issues regarding DBS for epilepsy. Just a second. It's not moving, right? Okay.
Yeah.
So I have nothing to disclose related to this presentation. When you talk about neuromodulation in epilepsy, you can talk about extracranial or intracranial neuromodulation, and we are going to be talking about today on intracranial neuromodulation, be it focused stimulation or spreading relay stimulation. This is just to give you an idea of what we have been doing over the years. And I would have to say that most of our procedures are still resective procedures, but modulatory procedures are gaining track in our center, and around 15% of what we have been doing is neuromodulation these days. It's impossible to start talking on DBS for epilepsy without mentioning these two pivotal studies coming from Medtronic and NeuroPace, the Sante study and the responsive neuromodulation study. Jason is going to detail the NeuroPace things, but what is important to notice is that despite the fact that they are using different hardware and different patient populations, the curves of the outcome is strikingly similar. It's very interesting to see that they got very similar outcome curves. I would start by talking about on others targets, not much studied, like the central median stimulation. Central median stimulation, I don't want you to go over all this slide, but just to mention that central median stimulation was pioneered by the Velasco group in Mexico City in their 1987 preliminary report, and all that comes afterwards is kind of based on their pioneer studies. The central median is very different from the anterior nucleus. The anterior nucleus is tightly net in the circuit of PAPES, and its connection is very restricted to the circuit of PAPES. Contrary to the central median, it has widespread connections to the many cortical and subcortical structures. So you can imagine that they are going to be used in different types of patients with epilepsy. As I mentioned, the central median is a very different nucleus. It's an intralaminar nucleus of the thalamus. It's a non-specific. It's part of the noradrenergic ascending reticular formation. It's totally different from the anterior nucleus. Although not seen in regular MRI scans, there are some tentatives of visualizing it, and I will show it. It's very easy to locate it using proportional coordinates, and it's like an oval structure lying on the posterior plane, passing through the posterior commissure at just above the level of the ACPC plane. Thus, from a targeting perspective, is not such a difficult structure. Since it's not seen on MRI, you need to use something to try to define if you got the correct targets. And you can use intraoperative CT, as you can see here, and you can just fuse this intraoperative CT with atlases or in the of your MRI data set that you have. This is coming from our last publications on long-term outcome of central median stimulation that we published in Seizure last year. Well, last year is 2020. As you can see, the electrodes are usually located at the level of the posterior commissure, 10 or 9 millimeters lateral to the midline, and they are concentrated in this small space as we expected, because we target this space. This is a stimulation not of the focus, but of relay. So, and we get a progressive increase in response, but it's not it not takes as much as time as we thought before to establish the results. So we believe that after 1 year of stimulation, we don't need more than a year to know if the patient is going to respond or not. This is a study coming from Korea, where they localize their active contact on the central median, and they try to differentiate between the parvocellular and the magnocellular part of the central median, and trying to establish a relationship between outcome and electrode position. They were not able to establish that one part of the nucleus is better than the other. And it's probably going to be, if there is some difference, that's probably going to you're going to need a huge amount of patients to prove that. Sometimes you are, when you target below the central median, your electrode is likely to be in the pretectal area. And this is how you can see that the electrode is in the pretectal area. This is the kid without stimulation of the pretectal area. And to the right, you see the kid with stimulation of the pretectal area. You see the upward gaze. And this is the typical stimulation, the result of the stimulation when you are stimulating just below your target. So it's just additional clinical information that you should use contacts above this one for stimulating. Intraoperative neurophysiology is also useful in central median stimulation. It's usually when you stimulate with high frequency, and by this I mean 130 hertz, the only thing you see is this DC shift oscillation. The above is the left and the below is the right hemisphere. And you see this DC shift, but you see no recruiting responses. And when you stimulate at 6 hertz, you see these time-locked recruiting responses that not only are time-locked, but they are bilateral, even if you stimulate unilaterally. So it's a very typical intraoperative response. We use it in our early cases, and but right now we don't use it anymore because we are safe with our targeting. But if you are starting using it, I would suggest that you do your first cases under intraoperative it's surface EEG, so it's very simple to take care of it. The patients for central median stimulations are those with Lennox-Gastaut or Lennox-Gastaut-like syndromes. But you can include patients with primary generalized epilepsy. They are all usually thought of being very easily controlled with valproate, but there is a biological continue, and patients with primary generalized could behave poorly in terms of response to the AEDs, and they respond as well to central median stimulation. And they could have a previous disconnective or stimulatory treatment, and the response would be the same. As far as programming goes, we use high frequency bipolar stimulation. Our upper limit is 5 volts approximately. You're going to see that when you use the hippocampus, you have to go lower. We increase 5.5 volts every week, and there's sometimes they complain of paresthesia in the ramping up period, but this takes less minutes of hours, not a problem for treatment, but it might be a problem when designing double-blind studies, because some of these patients will feel paresthesias. This is our preliminary series using central median stimulation in patients had already had callosotomy, and we were able to show that not only central median stimulation added seizure frequency reduction to this patient population, but that these patients also improved in terms of attention, which is a very clear-cut side effect of central median and welcome side effect of central median stimulation. And this is what central median stimulation does after regarding neurophysiology. The discharges, they do not disappear, but their duration is reduced and their amplitude is reduced. There are some intents of trying to locate the central median using imaging. And this is coming from Australia using MP2 range sequencing, and they showed that the central median might be distributed between the medial dorsal and the pulvinar. It's not clearly seen, but it's at least it's a beginning. And if you see, the interesting thing is that if you see their targeting, using imaging is about the same thing as ours using proportional systems. The only major difference is that they were targeting a little bit anterior than we are, and a little bit superior. But this is probably related to targeting strategy, because our strategy is to cross all the nucleus and not stay in the middle of it. This is another intent of showing up the central median coming from China. They use quantitative susceptibility mapping, and as you can see, there's a nice kind of shadow for the central median, and I do believe that in the near future, with refinement of imaging techniques, we are going to be able to see it better. I'm just not going to move to Hippocampal DBS. Hippocampal DBS was pioneered almost simultaneously in Belgium, Ghent, by Paul Boon's group, and again with Francisco Velaxo in Mexico City. It's a much newer technique than central median stimulation, and we first started with an open series showing that 40% of our patients were seizure-free. It's not seizure reduction, it's seizure-free after hippocampal stimulation in temporal lobe epilepsy. And we use the patient selection is basically those who have temporal lobe epilepsy and are poor candidates for any reason for resective surgery, had already been submitted to resective surgery, and one side that you're not going to be able to operate on the other one, patients not willing to submit it to resective surgery. And this is kind of a very big population in each mature epilepsy center. We use continuous high frequency bipolar stimulation. The upper limit is lower than for the thalamus, and there is no complaint at higher intensity, making it a very good technique for double-blind studies. We use a posterior entry approach following the axis of the hippocampus. We first take the anterior part of the head and then a point in the body. One thing that it's interesting for those who are starting with this is this insertional effect, acute insertional effect. This is a surface EEG during electrode insertion, and you see that there is in at least 60% of the patient and a huge increase in spiking just for electrode insertion. And I think if you see that, it's very likely that you are in a good position, though you are using imaging based targeting. Contrary to what you see in central median stimulation, if you use low frequency stimulation in these patients, you are going to be seeing very localized time-locked responses over the temporal lobe. It's not seen over all the brain, it's not seen in the contralateral temporal lobe, it's seen just over the stimulated temporal lobe. You also need to be more cautious while stimulating the hippocampus, because sometimes it's the focus itself. So you can trigger seizures using hippocampal DBS, something that you usually don't see with thalamic DBS. We followed on a double-blind control study on hippocampal DBS with a larger blinding phase and a larger recovery and titration phase compared to the other studies. And we showed that hippocampal DBS, contrary to what was seen in the Sante study, has an immediate impact in seizure frequency. This was noted only on the third month in this, both in the Sante and the NeuroPay study. And if you put them side by side, it's kind of easy to understand that continuous hippocampal stimulation, at least in patients with temporal lobe epilepsy, appears to be superior to both anterior nucleus and responsive neuromodulation. We have kind of 40% of seizure-free patients versus 15% on each of the other techniques. You can use intraoperative imaging to locate your electrodes that can superimpose to your pre-op MRI data sets. This is what you would like to have in our cases. We do it unilateral or bilateral, depending on the need of the patient. You want the electrode stuck into the hippocampus. And this is an example of a patient who is a candidate for bilateral hippocampal DBS. You see this lady had bilateral extensive perinodular ventricular heteropulpia. She has these seizures coming from both the right and the left hemisphere. Seizures documented, very clearly different from phenotype of seizure than electrographic type of seizure. And she received this hippocampal leads at the border of the heterotopia and the hippocampus. The idea was to stimulate both the heterotopia and the hippocampus, and she had a great response. She had 20 to 30 seizures per day, and now she has 1 or maybe 2 per year. This comes from our long-term follow-up of hippocampal DBS, published last year in Epilepsy, where we study the position of the electrodes in these patients. And for this, we divided the hippocampus in 5 locations. And you can see these are the positions that you can find the contacts. Except for the parahippocampus, all of our electrodes were either in the hippocampus, the majority in the hippocampus itself, as you can see here. And when they were not in the hippocampus itself, they were in the ventricle, near to the lateral border of the hippocampus. And just some of them, a small number of them, 3, were in the parahippocampus itself. So most of our contacts are really well located within the hippocampus. And we've shown that we have early responses from the first month on, and that complex partial seizures responded better than simple partial seizures or auras or focal without impairment seizure, whatever you want to call it. But these patients, complex partial seizures responded better than the simple partial ones. This is in terms of location, is in contrast with this paper, for instance, coming from a group using responsive neuromodulation, where they are very clear to state that at least 50% of their patients had no contact inside the hippocampus. So this is not what we aim. We think that if we want to treat temporal lobe epilepsy with DBS, we need to have the electrodes inside the hippocampus. We come to this at this point, where you see that different targets are used to different types of epilepsy. And by only seeing this, you note that we lack techniques for DBS for treating posterior quadrant epilepsy and Rolandic epilepsy. And this is likely going to be solved by using cortical stimulation techniques, using grids or strips and etc. In terms of seizure frequency reduction, is different to compare because the populations are different, but hippocampal stimulation is by far the most effective in its respective patient population. And it's also the technique that can use a higher number of seizure-free patients. There is a microlesional effect in each target, and you have to take it in consideration when you design studies, because if you have an insertional effect like in central median and hippocampus, your recovery and programming period should be larger to avoid contaminating the results of the blinded phase. Just to finish showing that we can use different neuromodulatory techniques together. This is a patient who received a VNS and a DBS. And we have been studying 16 of these patients, 8 that started with central median DBS, for instance, in Lennox-Gastaut, this time in Lennox-Gastaut, 8 of them started with VNS and 8 that started with central median and then received the second technique afterwards. At least in this series, more patients improved after VNS receiving central median than receiving VNS after central median, meaning that it's likely that although we do not know yet, but it's likely that DBS is superior to VNS as a second procedure, or likely as a first procedure, but it's really not clear from a statistical point of view at this point. We think that we are going to be seeing more neuromodulation in the future, and I just want to finish with this tutorial video. Is of course not made for many of you that are experts in the field, but for the people who might be interested in getting into it. It was put together by Tatiana Hertwig. She's a skillful neurosurgeon from the south of Brazil in a city called Curitiba. And I'll leave it with you.
This video describes the techniques for targeting the 3 most widely used structures in neuromodulation to treat refractory epilepsy. Our first target is the anterior nucleus of the thalamus. And the first step in planning when targeting a deep structure is to co-register the MRI sequences with the Stereotactic CT. To visualize the target, the most used sequences are STEER and T2, as demonstrated here. Due to great anatomical variability among subjects, indirect targeting should be avoided. The structure to be identified is the point where the mammillothalamic tract enters the anterior nucleus of the thalamus, as this area is related to better outcomes. If one goes back and forth on the coronal slices, it is possible to distinguish first the mammillary bodies and then the mammillothalamic tract, as confirmed on the axial and sagittal views. It is of extreme importance to address the vessels near the target, as they may limit the trajectory when implanting the electrode. The burr hole for entering the cortex is generally placed 1.5 to 3 cm lateral from the midline and 1 cm in front of the coronal suture. But this may be adjusted according to the safest trajectory. We should avoid major vascular structures and superficial and deep sulci. 2 approaches may be used when targeting the anterior nucleus of the thalamus: the paraventricular one and the transventricular one. The first, the paraventricular one, has the advantage of going lateral and not through the ventricle. However, as it has a very lateral entry point, it is more challenging to correctly position the electrode inside the nucleus on the sweet spot. Therefore, we rather choose the transventricular one, as it is easier to place the interspace of the 2 center contacts on the target. After the trajectory and the entry point are defined, it is necessary to go down from the cortex to the parenchyma to identify the major vessels that will be encountered. The first vessel is the callosal-marginal artery that may limit the trajectory medially, and after the ventricle is entered, there is the thalamus striatal vein laterally and the superior choroidal vein medially. Our next target is the central median nucleus, which is a thalamic nucleus of the intralaminar group. As it is not directly visualized on the MRI, it is necessary to identify the anterior and posterior commissures in order to define the target. After fusing the T1 sequence with the Stereotactic CT, the anterior commissure is visualized on the anterior wall of the third ventricle and the posterior commissure right above the aqueductus. It is also necessary to choose a midline point to correct the alignment of the images. The central median nucleus is located 10 millimeters lateral from the posterior commissure, at the level of the anterior commissure and the posterior commissure line. Once again, the burr hole for entering the cortex is placed 1.5 to 3 centimeters lateral from the midline and 1 centimeter in front of the coronal suture, but adjustments may be needed to avoid superficial and deep sulci and major vascular structures. Therefore, after defining the entry point, it is necessary to ensure no major vessel is crossed along the trajectory. The last target is the hippocampus, and this structure is readily visualized on MRI slices. Therefore, it can be targeted with direct anatomic methods. To identify it, a T1 MRI sequence with contrast is used. The first step when planning is to define an anterior point at the most anterior part of the hippocampus head in the coronal slice. The following step is to determine a posterior point at the middle of the hippocampus body on the sagittal view. After defining these 2 points, they are connected to generate a posterior entry point. This trajectory generally covers most of the hippocampus formation except from the tail, as it curves posteriorly and medially. A hard cannula, as the one used for the anterior nucleus of the thalamus and the central median nucleus, ensures not only an adequate electrode route, but also penetration within hardened structures as the sclerotic hippocampus. After defining the entry point, it is necessary to ensure no major vascular structure or superficial deep sulci are crossed along the trajectory. Thank you.
Thank you, Jorge.
Thanks so much, Arturo. This was terrific. Thank you. In continuation, I will ask for Dr. Gerard to start his presentation about RNS. Go ahead, Jason.
All right, thank you, Jorge. Are you seeing my slides?
Yes, I do.
Great, so I'm gonna go ahead and get started. Thank you to the committee, and it's a great pleasure to be here today speaking alongside Arthur. I really appreciate the invitation. I'm going to be speaking about responsive neurostimulation, and I'll call this RNS often in the same way that we refer to DBS. And we're going to try to take a whirlwind tour here in the next 25 minutes about the different techniques that can be utilized. We're going to talk about a couple different things that have to do with RNS, but I'm going to try to focus on surgical techniques given the audience. So if I fly through some slides about seizure types or workup, please forgive me because I'm trying to get to the surgical portion of the talk. I do consultant work for Medtronic, for Boston Scientific, and for a company called Longevity Neurosolutions. Longevity Neurosolutions does make cranioplasties, and one of their devices will be shown in this talk. Other than that, there's my funding sources are shown down here at the bottom as well, and I will be discussing off-label uses of surgical devices. The RNS, or the NeuroPace RNS system, is at this point utilized in the United States. It consists of 2 electrode arrays, which can be implanted in either depth electrode or cortical strip form, and a device that's implanted into a craniectomy done in the skull. And you can connect up to 2 of these arrays, which gives you, see on the right side, up to 4 channels of bipolar recording. So it's typically set up to record from, say, contacts 1 and 2 as a bipolar signal, and contacts 3 and 4 as a bipolar signal on each array. Just so people can take a look at the different electrode options that are available. On the left are the 2 different spacings of the electrode contacts as far as the depth electrodes. So there is a closely spaced electrode contacts, which is actually quite similar to the spacing in a Medtronic 3387 DBS electrode, and a 1 centimeter spacing electrode, as you see here on the bottom left, which is commonly utilized for medial temporal lobe or hippocampal electrode placements. Then on the right, you see the cortical strip, which has the sort of commonly used 1 centimeter spacing between the center of each contact for the strips, and there are 4 contacts on the strips. And then the other variable thing is the length of wire that's on the back end of the connector, because in these cases, unlike DBS, we don't have a lead extension. So the electrode itself connects directly to the device. There's no second connection. We'll go through this quickly because authors already covered some of this, but it's always important to show the pivotal trial results here. And what you can see is the treatment versus the sham stimulation arm to month 5, which shows a significant treatment effect. And this data, along with other data that was used in more long-term studies, allowed this device to get FDA approval in the US in November of 2013. The main publication is taken from Morel et al. 2011, the same publication that Arthur showed in his talk. And as we know, this gets better with time. So again, something to keep in mind is the timing of your improvement of your neuromodulatory device whenever you're trying to do trials or look at efficacy. And you also have to take into effect any implant effects. So we now have long-term studies out to 9 years as far as the % of seizure reduction in these patients, and you can see it continues to improve over time. Although there's some suggestion that as we've learned to utilize this device, this may be moving up. There's a recent open label study or a review that shows an 82% reduction at year 3, but you have to bear in mind that this is an open label study from the beginning, so it's a little bit different than doing the randomized studies that were done at the beginning. But I think it also does reflect how we're learning to utilize this device. And so we don't have to do quite as much learning with patient over time. Instead, we have sort of set protocols that we know work fairly well. As far as different neuromodulation approaches, as Arthur pointed out, we're going to see more and more neuromodulation in the field of epilepsy over time. And there's definitely several different mechanistic frameworks, but in today's talk frame, it makes sense to talk about at least 2, where you have a network approach, which is what's utilized in DBS, where we're targeting a critical node and modulating a network involved in epilepsy, versus the RNS approach, which takes a generally approach of stimulating at the seizure onset zone. So instead of using an overall global nodal modulatory idea, we're using a disruptive, where the concept is to disrupt abnormal resonance or abnormal synchrony by stimulating at the seizure onset area. This, of course, requires that you localize the seizure onset zone, or up to 2 seizure onset zones, which the RNS system is FDA approved for. Although I'll point out, and I'll show at least one slide towards the end, that these are not mutually exclusive approaches in the neuromodulatory treatment of epilepsy. Patient selection is, of course, critical. And this is the Yale surgical decision tree that we utilized. It's been updated slightly, but it was published in Frontiers in 2017. And you can see that, what it's probably seen very commonly throughout epilepsy surgery, where patients who have positive MRI findings with concordant workup will go to direct surgery. Patients who have diffuse or multifocal lesions or discordant data on their evaluation often go to intracranial study. But you can see that RNS can be utilized in cases where patients have functional cortex involved according to their mapping. It can be now combined with resection, which we'll talk a little bit about. We still prefer, as Arthur pointed out, resective surgery whenever feasible. But in these cases where there's eloquent cortex involved that's not, RNS can play a role. Patients who have MTL epilepsy, shown by MTS, but have preserved function through memory and cognition are actually good RNS candidates as well. And then we move over to the right side, you can see we can use RNS with unifocal or multifocal onset where there's functional cortex involved, and it can be, again, combined with resection. These are the common indications for RNS, multiple seizure onset foci, again, because it's approved for up to 2, an overlap of the onset focus with eloquent functional cortex, or in both cortical or subcortical regions. Bilateral temporal lobe epilepsy is a very common discussion point for using the RNS system, with a similar approach to the electrode placement that Arthur just presented. And then MTL patients who have dominant onset epilepsy with good memory function or failed prior resection. For instance, a patient who's had a prior left or right temporal lobectomy who now has seizures coming from the contralateral temporal lobe. And then in general, patients who failed prior resective surgery are another good subset of patients to talk about for the RNS device. The surgical approaches for RNS. So I'm going to try to go over 3 or 4 different cases because there really is no standard RNS approach. It's different from DBS in the fact that with DBS, you have established targets and sort of stereotactic, entrance sites. And so you can have kind of a overall generalized pattern for how you're going to do DBS, depending on your target and how the entry site goes with that. Bitemporal epilepsy is an exception to this, where there is a relatively standardized approach. So we'll talk a little bit about that approach. It's increasingly being combined. You're seeing a couple of publications now. We had an abstract last year on combining this with resection. And also, I can't skip over the long-term monitoring benefits of the RNS device. Some general concepts that I keep in mind or that I go through whenever I design an RNS implant. The first step you got to do is know what your targets are. So what are your target or targets, since we can have up to 2 different targets, and what electrode arrays are we going to utilize for that target? Then the RNS device itself, since it goes in the skull, it requires a craniectomy, and where are we going to place this craniectomy? And then we have to, of course, take in considerations from the patient's prior surgery. So in the big studies, 50% of patients have had a prior intracranial study. At our institution, it's actually significantly higher than that. The majority of our patients for RNS undergo an intracranial study to accurately localize their seizure onset zones, which become our targets. And what limitations do these are existing in these patients? So what are the patient's prior incisions? What are their prior craniotomies? Because you have to work with these considerations when you're planning their RNS implant. And then, of course, for future surgery. So we'll talk a little bit at the end about patients undergoing resection after long-term monitoring with the RNS. So what things down the road may come. For instance, if you have a bitemporal patient, but you think that the vast majority of their seizures come from one side, I would strongly advise placing the RNS on the contralateral side of the head so that when you do come back, or if you hopefully do come back for resective surgery, the RNS device is not on the same side as your surgery. And you do have to replace the device, just like with DBS. The newer device has a battery that lasts longer, but you do have to come back and replace it. So these things need to be kept in mind when you coming back to replace it. The things that we've learned over the years of doing this is, whenever possible, place the craniectomy near the top of the head. Specifically, try to keep above the temporalis muscle. It is much better to do a replacement when you don't have to cut the temporalis muscle every time you come back to do a device replacement. Also, the top of the head is really not used for anything, even wearing hats. Patients don't lay on the top of their head, so they complain a lot less about the device when it's placed near the top of the head. Keep wires away from the device, and also try to keep them away from the incisions line whenever possible. You'll see even in our experienced hands, it's almost never totally possible to keep the wires away from the incisions altogether, but you want to minimize this and know where they are. If you can, design an incision for the RNS that's relatively close to the RNS device, but not over it. This makes it relatively easy for accessing it when you come for replacement surgery. For instance, if the patient has a big sort of trauma craniotomy, temporal frontal incision from their implant for grids and strips, you're going to want to put the device somewhere near that incision rather than right in the middle of their craniotomy when you have to open the entire thing each time to get back to the device. And then I now am very careful to take good photos and put those in the patient's chart so that I know where all their wires are when I come back and can compare that to imaging. Another consideration for placing the device near the top of the head is any post-op imaging or on the road the patient may get. I only have CT scan on this talk because it was only recently that the RNS device was approved for MRI, but here you see a patient that had a prior craniotomy for their intracranial study, and so we utilized that for placement of their device, and you see how much artifact in an axial acquired CT scan that causes even in their sagittal, even their coronal reformats. So if you put that near the top of the head, you minimize the amount of artifact that you get for the deeper structures in the brain. The stereotactic techniques are required. I think, I'm not going to be dogmatic about any particular approach. I think it's most important that the surgeon is very comfortable and really understands the pitfalls and how to correct for those of whatever stereotactic approach they're using. The only general caveat that I will put out is I really try to avoid using frameless stereotactics for deeper structures. I'm sure we've all had the experience, the longer your trajectory is, the more inaccurate frameless devices become. And I'll kind of I'm going to move the robot kind of out of that. I'm talking specifically about things like BrainLab and Stealth. The stereotactic approach is going to define your head holding device. It's going to define what position the patient needs to be in. And then it's okay if you really need to, depending on the complexity of your approach, to stage it. And I've done that on multiple occasions. This can be done quite easily. Depth electrodes, whenever possible, I try to have a separate incision, although you can incorporate the depth electrode placement into an incision for the RNS device, and I'll show some examples of that. With strip array, sometimes it can be very helpful if you have a blank palette to use the craniectomy for placement of the RNS device to slide your strip electrodes underneath into the subdural space from the craniectomy. And then if you have a prior craniotomy, you can consider removing portion of that craniotomy to accommodate the RNS device and actually use the RNS ferrule or the housing that holds it as part of your cranial fixation system. And again, choose your weapon. Whatever it is that you use that you're accurate with, whether that's ROSA, whether that's frame, whether that's direct MRI, ClearPoint direct MRI guided, whether that's StarFix, or whatever your technique is, the most important thing is that you are comfortable, that you're knowledgeable and accurate with your stereotactic system. So for instance, the stereotactic system that you can utilize for bilateral MTL depths can vary. And I'm going to show you 4 different ways to skin this cat. So, whatever you're comfortable with, you can do. I prefer to design separate incisions again for the electrode arrays and for the RNS device. The reason for that is because it allows me to keep the slack from the wires away from the device. In DBS, we don't have to worry about that because the device is distal from the electrodes. But you don't want to have the slack loops for the electrodes be on top of the device. If they've had prior surgery, of course, you don't have a blank palette. Then you have to sit and design your RNS implant, incorporating the prior incisions and the prior craniotomies. And I bring up a head holder with prior craniotomies because I have had patients who had bilateral craniotomies for implant of grids and strips before. And I even 6 years after their implant, I've pushed one of their craniotomies in with the Mayfield head holder. So you have to be quite careful doing that. And then we were able to get an adapter that allows us 2, if not 3 pins on each side of the Mayfield head holder to try to avoid this. This is an example from Eddie Chang and UCSF that they published this past year of frame-based sitting. So this patient they're using the Lexel frame for placement of their electrodes. The patient's in a sitting beach chair or semi-Fowler, pick your nomenclature that you like for this approach. And they're using intraoperative CT scan. And again, you can see here on the bottom left, they're designing an incision that incorporates one depth electrode with the placement of the RNS device, and this is totally fine. As I said, I prefer to move the device up towards the top of the head and have a separate incision on the top of the head and tunnel the wires up towards that and leave whatever slack I don't need back here and get the device away from the temporalis muscle if I can. One of the considerations when you're using a frame, of course, is that your entry points may be quite close to the pin. So you have to place your posterior pins relatively low. And again, everybody who's used a frame knows that there's a fine line between having good low and too low, where they'll be down too much in the cervical musculature and have a tendency to scythe as the posterior portion of the posterior fossa is diving away from your pins. We also find, agree with what was published by the UCSF group, that the best trajectory, since in our hands, what we try to do is put the first contact in the amygdala, is a low entry point, so that you have the barrel of the hippocampus and then one contact in the amygdala. This often gives you this low entry point. And so here you see it mapped out to make sure you miss the pins. From Baylor, Dr. Samir Sheth group published another approach using the ROSA robot and prone positioning for placing this type of electrodes. And you can see here in this picture that they're using actually the pins as a registration point for the ROSA. So here you have intraop CT with a Lexel frame and prone positioning. Again, you see the pins are placed fairly low in order to accommodate for the entry site. This is our case here. We're using the ROSA robot with the sitting position. So one of the reasons we like this position is it allows us to place the posterior electrodes and then have access to the top of the head here. And again, I've drawn you the incisions I like to use with small linear incisions for the entry sites, and then a separate curvilinear incision towards the top of the head where I tunnel the electrodes to for the placement of the RNS device. Again, if you have a hypothesis that the patient has bitemporal epilepsy, but one side seems to be much more likely to be the ultimate onset side than the other, then try to put the device on the side opposite from that potential future resection. And then a fourth approach, one that I've actually come to like the most, is use of direct MRI guided placement of the DBS electrode. So I'm using what's called ClearPoint Stereotactic system here. The patient is prone because you have to put the patient in the MRI scanner. Apologize for that. And you can't do that when they're in the sitting position. It's what I like about it is I see this is real-time imaging. You see here in the top left, and I know in real time that this electrode is going right down the barrel of the hippocampus. This is the MRI patient in a prone position. You can see it's a relatively large patient in this instance. You do want to flex the neck as much as you can, but you're limited by the fact that you can only lower the Mayfield head holder so far because the table has to be able to go into the bore. So you do sometimes end up with a pretty vertical trajectory inside the bore, and we'll have to break off their stylets. And another thing you can do is combine your different stereotactics, and you'll notice fatigue on this patient's head as I'm using BrainLab to help us. So I'm combining BrainLab and intraoperative MRI guidance, and you can see that this can give you a really nice result. You then have to reposition the patient for placement of the RNS device. Or again, if you really are finding that this is taking a long time, you can stage these. I've staged these procedures quite a bit and actually find that I prefer that for a couple of reasons. One of which is that the patient needs to have teaching done with the RNS device. And if they've had an 8 or a 10-hour case, and then the next day the folks from epileptology come and try to teach them how to use the RNS device, they're just totally out of it, and they still haven't recovered from the surgery. Whereas if I break it up and they come back and they just do a quick 1-hour surgery where I just make a quick craniectomy, put the device in and plug it in, they're wide awake and essentially ready to go home by the middle of the day. And then when the RNS teaching people come to teach them about how to upload their data and utilize their device, they have no issues. Whereas if it's been a long case, they'll often end up staying an extra day in the hospital just for their teaching. Securing the depth electrodes, there's multiple different techniques. Some people like using burr holes. I prefer to use a burr hole and use some type of an electrode holder. I don't really particularly care for the RNS device because it's a plunger. You plunge it in when it holds the device, and you can't, it's opaque, so you can't see if you're pushing the electrode when you put the plunger in. I will actually use stim locks from Medtronic for holding my RNS electrodes, and it holds them just fine. They're a tiny bit smaller than the DBS electrode, but it holds them just fine. Other people prefer to do it like an SEEG approach, where you drill your hole and then place the electrode directly through the hole with the frame and with ROSA, and this is totally fine as well. NeuroPace does recommend against placing plates across the lead, such as dog bones. Sometimes I do that though. Make sure you have a cover on the over the wire to protect it. They've reported fractures of the lead wire with the dog bone. Another option is to place a dog bone or some type of a plate next to the burr hole and tie the electrode to the burr hole with a right angle turn. This can also be done. To show you what it looks like with 2 foci, so let's move on from a depth only study Again, I'm going to skip pretty quickly through the workup stuff just so we can focus on the surgical technique. But this patient is relatively young. This patient had epilepsy onset relatively young. They've had seizures for a long time. They can have up to 40, 50 a week. They have a history of complex partial seizures, but no real history of generalization. They've had some changes in their seizures over the last few years, and they're now more and more unaware of their events. They have dysplasia shown on the MRI scan here. And this is a slide that we make in our conference that sort of puts together all the data that creates the hypothesis that we have for the intracranial study. This is a picture of the patient's intracranial study that we did. You can see our hypothesis, we're mostly left in this workup. And this is a picture of this patient had a craniotomy with grids and strips. I won't go through all the EEG, but here at the bottom, you can see the marked onset zones in this basal strip, sort of right between posterior temporal and occipital regions, as well as this temporal parietal occipital junction region here with the patient's seizures. So here's an onset zone that this is a picture actually showing an inferior view. So this is actually underneath the posterior temporal occipital, sort of in that occipital temporal pathway. And this is more of a temporal parietal occipital junction onset zone here. And this is the patient's mapping. Then this shows some of the strips. Interestingly enough, this basal strip, strip F, has verified consistent language in this area, including verbal naming, reading, writing comprehension. And so you can see these, we've all seen this redistribution of language function. We did generate a seizure with testing in this area as well, which is close to the strip, even though the strongest onset point seemed to be up here where this red circle is. And she did have difficulty doing spatial tasks and tracking when we did some stimulations across the top of the grid up here. So for this particular patient, we decided to do RNS as this area could not be resected. And what we do, our technique for doing this, again, this can vary from center to center, is we use our frameless. So in our case, it's BrainLab, it can be Stealth, it can be whatever your frameless system is, to mark our points of interest. So we put these 6 points of interest that are going to define our upcoming implant. You want to minimize them. If you mark every spot where there's a seizure onset, it gets really confusing trying to navigate back to these spots. You just want to define the strip F, right? We want to define that orientation. So you only need 2 points to define your line, and then define where the electrodes are going to go in the more temporal parietal occipital area. We then remove all the electrodes. And one of the techniques I learned from Dr. Spencer with his years of experience is he uses Gore-Tex for the duroplasty, which has a big advantage in the fact that it does not stick. So when you come back, his approach was always, you're probably going to have to come back someday. So it gives you easy access without having the scarring to the cortex. We then design, at this point, a titanium mesh. Another technique I learned with Dr. Spencer is we like to wait, especially if it's been a long intracranial study, and not implant long-standing hardware right after the intracranial study. And so we sort of hand mold them a titanium mesh cranioplasty, remove the electrodes, and we have them heal for 6 weeks before they come back for their definitive surgery. Then we can quickly remove the titanium mesh. We have the Gore-Tex duroplasty, which comes right off the cortex without any scarring, and we can quickly do our implant. Sometimes you do need to do additional bone work for your implant as well. And we prefer to do that outside of the intracranial EEG study, mostly for infection risks. And since we started doing this approximately 8 or 9, it's actually been about 10 years ago, we've had no infections with our implant of long-term hardware. One of the considerations is a recent publication that came out of looking at our temporal lobe study, our temporal lobe patients over the last 20, 25 years, is that those patients that fail this red line, they have rapid propagation. So patients whose seizures stay in the temporal lobe tend to do very well. They're probably the ones where we hear about the 70 to 80% seizure freedom rate. But in this survival curve, you can see that if their seizure are propagated outside the medial temporal structures in 10 seconds, that this drops to more in line with the average long-term data, which is about 50%. And if they propagated to other nodes in less than 5 seconds, it was 100% fail rate. So in these patients who have rapid seizures, we will often utilize the RNS system for those patients. So after the design, this is what the implant X-ray for that particular patient looks like. We again co-register all of our imaging, including new imaging after the removal of electrodes. We then navigate back to the places, our onset zones where we want to place our strip arrays, and place strip arrays to cover that basal area as well as the temporal parietal occipital region. And then we removed a portion of the craniotomy flap for placement of the RNS device. We have placed extra electrodes. Again, you can see here, we've replaced the extra electrodes, and you want to keep those on this side of the device, on the side where the connections are, but not on the back side of the device. And that's because when you return to replace the device, you want to be able to approach it from this direction. And I'll show you that here in a second. So here's an example of this where you've had this complex repeat craniotomy implant. You can see in this case, we've designed to use part of the flap for the placement of the device. And in these particular arrows here are just to show you some of the tips of the trade, the tricks of the trade. This is the set screw that you have to get to before you can remove the device, but you want to approach it from this green arrow. And you can see there's nothing in your way. If you approach it, you're close enough to easily find the device without encountering any wires, because all the wires are kept at this yellow arrow on the other side. So rather than have my wires come out this burr hole or this burr hole, I specifically wanted to come out this more anterior burr hole. You can see some temporalis muscle up here. So you don't really ever need to go back here. You just need to come here and be able to carry your dissection to this area to replace the device. And you can see the Gore-Tex duroplasty underneath the device here, the white arrow. And then here's an extra electrode that's placed off to the side, but close enough that you just carry your dissection a little bit further. And if you wanted to disconnect and connect up this device, you can do that. And we'll often have epilepsy conference each time the patient comes back for a battery being low, and discuss how well they're doing and whether or not we want to switch over to one of the other electrode arrays that's available to the patient. We're also hopeful that at some point we'll be able to connect up more than just the 2 electrode arrays. As I mentioned, you can combine these approaches. So this is a combination. This was the first implant of the central median thalamus in a patient that had broad onset bilateral parietal epilepsy, where we use the parietal strips that are placed here through the craniectomy for the device for our seizure onset zone and modulation in the hippocampus to try to treat their seizures. And what we discovered that's very interesting is you can actually see the patient's seizures in the central median nucleus of the thalamus, shown right there. Another patient that had failed prior, a different approach, and this time we're going to use a custom cranioplasty. So this patient's failed prior surgery. I'm going to go through these very quickly. You can see their prior implant. Here's their prior surgery, which was bordering up against Broca's in language, as well as motor strip, and had to be stopped. She had MSTs over language and sensory, but her seizures continued. And in fact, 6 years later, she was in our ICU in basically focal partial status, where her face and hand were twitching almost constantly. I'm sure everybody loves doing a repeat intracranial study. And this is just an example of what this looks like. We placed a depth electrode into the face area, which was her main issue, was constant facial twitching. And we're able to get a grid in here. You can see the old Gore-Tex here, which did help us with the approach. And the patient went on to have seizure onset zones shown here, mapping that's shown here, where our electrode was indeed in the face area, but there was also mixed language. Here you see motor sensory, and you can see there's overlap in this area. So given that she'd already failed resection, we again decided to do RNS, and we gave her this titanium mesh with the new Gore-Tex, allowed her 6 weeks healing. Because she had multiple craniotomies, and it was very difficult to do her repeat intracranial EEG, she essentially had a very poor flap. And so we designed a custom cranioplasty for her. And this particular cranioplasty is actually designed to hold the device itself in the cranioplasty. So you see we covered the multiple onset regions that are here. This one seemed to be more consistent, but this one was also involved. And so we covered all these areas using a grid pattern, and then gave her a custom cranioplasty with the device housed in the cranioplasty. The nice thing about this cranioplasty is that it's smooth once you've finished everything, and so that you don't have all the ridges that you have from the device placement. Another approach you can use, which is I think a very good approach, this is again from the UCSF crew, they border and they create broad area neuromodulation, and they've given some examples here, and I appreciate them giving me this slide to show you, where they've set it up rather than doing what we often do, which is place them right next to each other in almost a grid-like fashion. They create an outline of their areas that they want to modulate, given that they're only using 2 strips, and this can be very effective to create a broad field. I'm going to skip over some of this. This is, again, another patient who had 2 onset zones, and it was overlapping in dominant hemisphere, who underwent a combined resection, you see here, as well as placement of RNS. So here we're designing our RNS in the flap. This is the placement of the housing. Here's the device installed. But unfortunately, this patient had multiple surgeries, had a history of Norse, complex epilepsy. And their epileptologist called me about 3 years after their implant and said, it looks like he has sunken flap, which is something very odd. And sure enough, we got a CT scan, which confirmed that his bone flap had mostly resorbed and his RNS device was essentially floating in mostly soft tissue, which is what you can see here in this particular picture here. And so we again designed him a custom, this time a PEEK cranioplasty flap, which you can do with a cutout for the device to replace that flap, and then reconnected his RNS system after it was placed into this device. Finally, I'll just quickly cover some of the long-term monitoring. Apologize for the misspelling of the title there, for this device, which can be highly effective. We can use lots of data for seizure prediction, seizure warnings. We have what's called a fifth stimulation study. And what the RNS device does, when the detector goes off, it gives a burst of stimulation. It then goes back to detecting. And if the detector still senses seizure, it gives another burst, and it can do this up to 5 times. For FDA approval, it shuts off after the 5th burst of stimulation. So what we've gone to doing is giving high current stimulation at strips or depths where they would have a side effect. So we try to find a side effect. And then in the 5th stimulation, we include the stimulation that creates a side effect for them. So that, for instance, if there's sometimes we'll get a little bit of dural sensation that'll give them a little headache pain, and they can recognize that as a way to say, hey, your device just went off 5 times and the seizure is still happening. So almost as a way to warn the patient that they may have a seizure. Of course, we can document seizure awareness and seizure counting, but we've had some other very interesting findings, including medication effectiveness, lateralization of bitemporal seizures, and circadian rhythm. So this is, again, another paper from UCSF that shows that you can actually map long-term oscillations, even longer than a month, with these different type of rhythms with this device. And you can also see that they may tend to happen for certain patients in different parts of their phase of that oscillation, which can be very helpful for predicting when patients are more likely to have a seizure. Another thing that's been very interesting from Yale with Dr. Hirsch as the lead author is patients that are going back for resection after long-term monitoring with bitemporal lobe epilepsy. They went through 157 patients who had bilateral MTL implants and found that 25 of them underwent resection after monitoring with the RNS system. 9 patients were found to have only unilateral electrographic seizures, and all 9 of these patients became seizure-free after MTL resection. Most of them kept their RNS device, so we have electrographic proof of that. The other 15 patients that still had bilateral onset that were treated with resection, all of them had at least a 50% seizure reduction, and 8 out of 15 were seizure-free at follow-up. This again shows all these patients on the right here, that all 9 patients with only unilateral onset did really well. And then the patients in the bottom part didn't do quite as well, but they were more like they're still like our typical temporal lobectomy patients, especially those in the past, like for instance, with Dr. Spencer's publication about bitemporal epilepsy and resecting the more diseased hippocampus had similar, maybe not quite as good, but similar outcomes. Again, all 9 seizure free if they had 100%, if they're all the seizures onset on one side. 8 out of 15 with bilateral onsets were seizure free at last follow-up, but these are not long-term outcomes. Bear that in mind. And most of these patients, one key is that most of these patients had 90% of their seizures coming from one side. So I think that what we learned from this study is that if your patient has been studied for 2 years and all of their, which is you see the median study, all their seizures coming from one side, this is an excellent resection candidate. If at least 90% of their seizures are coming from one side, again, the patient has an excellent odds of having a good outcome from resection. And with that, I'll wrap up and say thank you again to the committee for letting me give this presentation, and happy to take any questions.
Thanks so much, Jason. This was a fantastic presentation. I appreciate the overview and the important tips in terms of implantations and also indications. So I think we have perhaps 10-15 minutes for a Q&A session. And I would like to open the questions to our panelists, Guy, Berto, Chris, if they have any questions for Artur or for Jason.
Jason, can you unshare your screen?
Absolutely. There you go.
Just when I noted that Francisco Velasco is in the audience, I'll try to bring him up let's see if I could do it. Francisco, if you are there, no, he's not there anymore. So no Francisco today.
Okay. I would probably start questioning. My question is going to go to Artur. Artur, you present a nice series with patients with Lennox-Gastaut. And the question that I have is how many of those patients underwent callosotomy before? Do we, in your selection criteria, do you choose to do callosotomy first for those patients, or you choose to do DBS, or hit or miss? What do you do?
Actually, we have a comparative study comparing VNS with callosotomy and callosotomy with DBS, and both studies have quite similar results, meaning that callosotomy is much better for patients with atonic seizures, which respond very worsely to VNS. VNS is a very bad option for patients with atonic seizures, and DBS is in the middle of VNS and callosotomy regarding atonic seizures. So our policy today is when these patients have multiform seizures, and some of them, the basic symptom is atonic seizures. If the main issue is atonic seizures and falls, these are typically the patients that are coming to the office wearing helmets. So these patients will respond better to callosotomy first. And then you can follow in any other type of neuromodulation afterwards. If the patients are do not have atonic seizure as the main seizure types, you can do either of the three, VNS, DBS, or callosotomy. But as far as invasiveness goes, I think you should consider first DBS or VNS. As I mentioned, we have a prospective study comparing the efficacy of crossovers groups from VNS to DBS and then from DBS to VNS. And as far as it's not finished, it will take another year and a half maybe. But so far, the mid-interim analysis showed that DBS is superior to VNS in Lennox-Gastaut patients. So if this is going to be the final results, we are probably going to be starting with DBS for Lennox-Gastaut that do not have atonic seizure as the main seizure type.
Very good. Thank you.
Jason, I've got a quick question for you, just to clarify. So your workflow, so say you have a patient who you're putting a subdural electrode array in, and then you're going on to do RNS. You were showing a cranioplasty phase in there and then going back to their bone flap. Is that correct? Your bone flap's stored and frozen all this time? How exactly are you doing this?
Yeah, so that's thanks for the question. So yeah, you can do it. I mean, obviously other people do it where you place the RNS device right after the intracranial study. We will in instances do that, but if especially it's been a long intracranial study or they've had a CSF leak, we will leave their bone flap in the freezer and put the titanium cranioplasty mesh in place. Leave that in place for about 4 to 6 weeks. Usually it's about 6 weeks, and then they come back for the definitive implant. And since we started doing that, we've not had any infections at all with our long-term implant. I failed to mention that we also use, as a lot of people do, vancomycin powder now with all these implants. But other studies other centers have reported putting their RNS devices in right at the time of explant, and have good outcomes as well. But this has been a technique that we found works very well for us. So yeah, we do leave the bone flap in the freezer for 6 weeks, and then put it back.
Very good. I have a question to Artur from Dr. Cosgrove. He asked about what is the spacing of the DBS that you implant? What is the spacing between the contacts for the DBS that you're using, Artur?
Yeah, that's a great question, because we are borrowing electrodes from other functional procedures, and the most used electrodes in other surgical procedures are the talking about the Medtronics, right? It's the 3387 and 3389 that would give you a span for the context of 1.5 centimeters. This is very bad for the hippocampus, which is a kind of a 3.5 centimeter tubular structure. So what we are doing right now, we are borrowing, if you use Medtronic, we are borrowing the 3391 electrode, which spans for 2.5 centimeters. It's used by people doing psychiatric or other types of procedures like OCDs and etc. But it's much better to cover the hippocampus. Boston electrodes are much better if you use them in terms of coverage. But what we really need is an electrode specifically devised for hippocampal stimulation. It's not there in the market. We are pressing the industry to provide us with one, but they come with all types of regulatory issues before putting them in the market. But I think that even if you're using RNS, you'd better have a better electrode for stimulating the hippocampus. I'm pretty sure the people who use RNS in the US would love to have a better electrode. So right now we are borrowing electrodes, and the better one coming from Medtronic is the 391 OCD electrode.
Very good.
And I think I finally got Francisco. So
Great. In the meantime, I have another question for Jason. Jason, we have two, in fact, it's a question for Jason and also for Artur. So we have two talks, one about DBS and another about RNS, and both methods can be applied for the hippocampus. So I would like to know from each one of you opinions about why to do a technique versus the other, or we just don't know when to use DBS or RNS for hippocampus stimulation. What do you think, Jason? Do you see any pros and cons, or what are the advantages of the RNS versus the DBS for hippocampus stimulation, and vice versa for Artur? I think Jason is perhaps frozen.
Frozen?
Yeah, I believe so. So Artur, maybe I can shift this towards you. You understand the question? There are some...
Yeah, I understood. I just want to see if Jason is not back from frozen. He's back. Okay, so. You're mute.
Can you hear me now?
Yeah, I can hear now. Okay. Jason, did you got the question?
Okay, I apologize.
It's okay.
I did hear your question, and then I lost power, so I'm back up on battery here. So yeah, I think that's a great question. And for us in the United States, we use RNS whenever we want to approach the hippocampus, and I think that is largely because it's FDA approved. And I'm not, I didn't get to hear Arthur's response, but I don't know that we have data to suggest that one technique is better than the other. You know, right now, if we want to stimulate the hippocampus with a temporal epilepsy patient, for us in the US, that's the RNS, and we've had good results with it. So, you know, I think it's more about experience than it is data that shows one method superior to the other. I will say that the ability to record intracranial, you know, ECOG data over long periods of time, as I've shown, is a huge plus and for these patients. And so that, I think, for us will still be our first approach. Although, you know, with the devices coming out in DBS that can also record data, we'll have to see how that shakes out.
Artur, do you have any?
Yeah. I think, first of all, I would like to talk about the rationale. I think the rationale for responsive neuromodulation is the way to go. It's certainly much better to respond whenever you need than not to do it in a continuous way from a rationalizing perspective. But this is just the theory of it. Additionally, one nice thing about RNS systems, but there are others coming up that are able to record prolonged EKG recordings, is this ability to provide prolonged years-long recordings for these patients. So the rationale of being able to prolonged EKG recordings and being responsive is great, but the problem is how the results are at this point. It is true that there is no direct comparison between continuous DBS and responsive neuromodulation. There's no head-to-head comparison, but there are specific studies on both techniques. And as per the results published so far, continuous hippocampal stimulation is much superior to responsive neuromodulations in terms of patients who become seizure-free. Again, there are two separate studies with different technology, with different patient selection, and no head-to-head comparison. But I would say that at this point, if I had the opportunity to work with both techniques, I would do continuous hippocampal stimulations in my patients with temporal lobe epilepsy, despite the fact that I will be highly in favor of further developing the technology and knowledge about responsive neuromodulation that I think would occupy a major role in the future. But right now, continuous, and as per the response, as the published data, continuous hippocampal stimulation is better than both AN stimulation and RNS publications.
Very good. I have another question here from Dr. Ivanovich, also for Dr. Gerard, asking any trials with neuromodulation RNS after failed temporal reoperation?
So, I don't know if there's a specific trial for that patient group. They are certainly included in the large overall patient group. And there is good data that they do just as well as patients who haven't had resection before. So, they're really, when in the larger studies where they've broken off the different temporal lobe epilepsy, patients who have VNS, patients who have had prior section, there is not a clear, obvious statistical difference depending on the different types. Because a lot of us thought that, for instance, bitemporal epilepsies were going to have the best response. But they show that these patient groups all have a relatively equivalent response rate.
Very good. Excellent. Any more questions from our panelists?
I think Francisco.
One thing I will say, sorry.
I would like to congratulate the presenters because this was an excellent session.
Can you show up, Francisco, or you're hiding yourself for any specific reason?
No, I can show. See,
yeah, but you still don't see you.
There is not much to see. I have to. Okay.
Okay, good.
Right. Well, I want to congratulate the presenters because there was a wonderful session. And I have two questions. First, how long does it take to have a positive response in the case of direct DBS or the responsive stimulation? That's an important question because some publication says that for responsive stimulation, the delay is too long of years. And in cases of DBS, we can have an immediate response. Even there are some publications from England, the insertion of the DBS electrode in the central median can render the patient seizure-free for months or years. So I think that's an important point because at least in our population, everybody is anxious to have some kind of response, and it's difficult to adjust the parameters of stimulation if we don't have an immediate response to how you set up your parameters of stimulation if you don't have a clear-cut response to your technique. That would be a question for Dr. Gerard. And the other thing is that it's very important that the case of anterior nucleus, the delay for a response takes about from 2 to 3 years to have some above 30% response. And in the case of the central median nucleus, the response is of months, as Dr. Gutierrez had shown. So I would like to hear your opinion about that.
Artur,
Yes, thank
do
you.
you want to start? Or Jason? Yeah.
I think now is Jason's first.
Sure, I'll happy to go. Thank you so much for the question, Dr. Velasquez. You're right. With the RNS system, there is a delay in the response, and some of that is built into the way the system works. And a lot of it has to do with the complexities with doing responsive stimulation. So unlike DBS, where we have relatively well-identified stimulation parameters, at least for starting, and the ability to get that stimulation going right away, with RNS, you need to record that patient's data. So most centers, including ours, will only have the device on recording for the first month that it's implanted. We also know from data that's now been published that the recordings will change over time, and they tend to stabilize at about 6 weeks. So you have a built-in delay of at least a month before you even, sometimes it's even longer, before you even start the stimulation. So what we often see is an implant effect, and then you get the stimulation going. So you're right in the sense there will be some delay. The slide I showed with the open label, more recent open label study shows that the response rate, having a 75 to 80% response rate, has now been pushed up to 3 years. And I think a lot of that does reflect how much we've learned about how to set the system, how to program the detectors over time, so that we're now quicker at that. But there still is going to be a delay in time of at least several months, usually, before you get your response from the RNS device. With the ANT DBS, we don't see much of an implant effect. I think Arthur has shown that as well. Sometimes with CM, you will get an implant effect. So sometimes that sort of also plays a role, I think. Art, do you see a big ANT implant effect?
Excuse me? I didn't hear your question.
The question was,
Arthur,
if
do you see a big ANT?
Oh, it's toward me. Okay. No, actually, ANT, we don't have. We've seen some patients with insertional effect, but it's definitely not the majority, and they are not as expressive as you see in the hippocampus and central median. I think there, in terms of the timing of response, you have two issues. The first issue is hardware related, and the second issue is target relation. The target related issue is that you can expect earlier responses if you're stimulating the foci. If you're stimulating the relays of spreading of epileptic current, then I think you should expect a later response than while you're stimulating the foci. So meaning that it's very clear for me that it's very easy to understand why stimulating the hippocampus yields good results from the first month on, as we've shown in our long-term and the double-blind studies. And it's also understandable why, if you stimulate the thalamus, it will take longer. The problem is how long. Literature is considering years. And although I think in our thalamic patients, although they take a little bit longer to get their final response, it's not 3 or 4 years. By the end of the first year of full stimulation, by the first year, you can easily tell which patient is going to be a good responder or not. From the RNS perspective, I think that we are all learning how to use the system, but when we know more exactly how to use it, I think we are going to be able to forecast by the end of the first year who's going to be the good responders or not. Not to mention that they cannot improve. I can understand the idea of improving the results because you are modulating the network. I can understand this. But definitely, if someone does not respond by the end of the first year, it's very unlikely that they're going to respond afterwards. And if they don't respond after 1 or 2 months with direct focus stimulation or hippocampal stimulation, they're very likely not going to respond 3 years afterwards.
Excellent. Very good. Any more questions from the panelists?
I'd just like to mention how happy I am to see you, Francisco, even if by digital means.
Very good.
Incidentally, who took that film that you show? It was very, very nice. I think you should say that to other people to know how to place the electrodes for DBS too.
Yeah, you have to thank the hard work of Tatiana Hertwig and Fernando. Fernando is a technician that works in all our cases, stereotactic cases, and she was the one who put together the video. And I agree, it's a nice start for people who are interested.
Excellent.
Excellent.
Well, I think it's almost 11:25 here, and I thank you again. The great session, Artur and Jason, fantastic, great discussion.
Thank you.
And I'd like to. We have a couple more questions in the chat. I will forward those questions to you, and hopefully we can answer them offline.
Sure.
With that said, I think it's time to closure. And for the attendees, please stay tuned for the next webinar next month. Thank you so much.
Excellent.